Hello and welcome. My name is Danielle Abel, and I will be presenting a case today on concussion and post-concussive syndrome. I did provide a little bit of evidence in the presentation just as an intro, but I'll flip forward to the case. Key points in this case, we saw the patient in the outpatient setting. She is a 25-year-old female electrician. She's presenting status post head impact. So she did hit her head on a lighting fixture, was immediately, her loss of consciousness was immediate. Then she was transported to the ER where she was diagnosed with a mild TBI and sent to neurology. The neurologist then referred her to physical therapy, and we saw her 8 weeks status post her concussion. Her primary complaint, she presented with headache, dizziness, neck pain, blurriness of vision, fogginess, difficulty focusing, concentrating, and mild light sensitivity. She also reports feeling her increase in her anxiety and depression, which was previously diagnosed, and difficulty rising from supine due to dizziness. She also reports that she's having trouble getting through her workday on a day-to-day basis. And she also does have a history of an irregular heart rate, which is important later on. So in the initial evaluation, a couple of important things to note. Her blood pressure was elevated initially, so we did monitor that throughout the case. Her cervical range of motion was a little bit limited and did produce moderate symptom presentation, including dizziness, stiffness of the neck, and headache. Her strength was moderate as well, and I also wanted to note her PHQ-2 cumulative score of 4. So we wanted to make sure she was also being followed by neuropsych or a psychologist. We also did a graded symptom checklist, which revealed 20 symptoms and a symptom severity score of 83. On the SCAT-5, her concentration lacked proficiency, and also she did not do very well on her neuro exam at first due to failure of coordination and double vision with head movement, as well as some balance errors as well. And her Buffalo concussion treadmill test initially, she did not have a ton of aerobic capacity due to the fact that her symptoms did increase by greater than 3 points throughout by level 8. On the vestibular examination, she did have abnormal saccades, both vertically and horizontally. She demonstrated difficulty achieving the target and implementing a corrective saccade in all directions. As far as the vestibulo-ocular reflex goes, both were abnormal. She was unable to maintain the advised pacing, and she did have onset of headache and blurry vision. We did clear for BPPV with the Dix-Hallpike because of the supine to stand symptoms and dizziness. She did not test positively on the Dix-Hallpike for BPPV. Due to the ICF model, we wanted to make our assessment of a mild TBI, also post-concussive syndrome, because we are at that 8-week mark, and typically concussions are resolved at about a month, typically. We are testing the vestibulo-ocular, MSK, cardiovascular, and cognitive symptoms, and that's what we want to address in treatment to get her towards her goals of being more involved in her activities, lifting, walking, ambulating the community, eventually getting back to work. Some environmental factors I wanted to mention. She is a workers' compensation case at this time, and she's not sleeping very well, which can cause undue stress on her system. So for the treatment plan, we did want to see her 2 to 3 times a week. We made a huge emphasis on education of the passive phys, return to her participation levels appropriately, the prognosis of concussion and post-concussive syndrome, as well as pain neuroscience education. All of the research showed that it's important to have an initial period of rest followed by a graded return to both mental and physical activity using multimodal physical therapies. So that included aerobic exercise, working on her vestibulo-ocular system, working on her balance, and making sure she was dual tasking because she did have to return to work and do work activities while doing all this thinking about work. So to be continued here, we wanted to also educate her on her symptom management. A lot of the research says treatment should not bring on symptoms. However, there is some research that does show that in order to not get into a fear avoidance type of model, that we want to onset symptoms 1 to 2 out of 10 and educate the patient that a little bit of symptom onset is okay. Then we take a rest. And then once the symptoms have resolved, we then return to the activity as to not get into this fear avoidance behavior. We did a few referrals. I did go to the neurology appointment with the patient when she did have one, just to make sure the care team was all on the same page there. But there are a couple other referrals that we wanted to have for her, and she was able to be seen by all of those specialists. Couple of interventions here. We basically focused a lot on the vestibular system, a lot on her balance, a lot on this aerobic tolerance, and putting it all together to making it a little more complex as she did progress and had less symptoms. So on the progress assessment, her blood pressure was regulated, cervical range of motion was normal, onsetting only minimal symptoms, min symptoms throughout the evaluation or the progress assessment. The PHQ-2 was now a cumulative score of 2, so her feelings of depression were going down a little bit. The concentration stayed about the same on the SCAT-5, but her graded symptom checklist, number of symptoms, and severity went down. Her neuro exam improved, only having difficulty with moving her head, and her aerobic capacity improved on the Buffalo concussion treadmill test. The saccades did improve. She did still have a corrective saccade to the left on horizontal, however, all other resolved. And her VOR, she was able to tolerate a lot better with only mild symptom onset. So in conclusion, her prognosis continued granted return to activity for about 4 weeks. We want to monitor her symptom onset with work-related activities. And if she's symptom-free or having very minimal symptoms, we would clear her for full return to work, full return to participation. What I learned about this case, it taught me a lot, especially about post-concussive syndrome and the involvement of the autonomic nervous system in the treatment of post-concussive syndrome. So there's a lot of heart rate and blood pressure dysregulation that can be evident in the patient's presentation of symptoms. So knowing that that's going on and addressing aerobic capacity so we can regulate the cardiovascular system a little bit more, I learned was super important. So I learned a lot about that. Things I would have done differently are education on symptom management and a stricter return to our participation, just making sure the patient does know that we do want to onset just that very little amount of symptoms while we're doing activity and then take a rest as needed. So eventually she can improve her tolerance to all of these things. So giving her a more thorough education on this concept, as well as really guiding her very strictly on her return to participation, because I know sometimes it was a little confusing and she really did want to get back to work. So that was a difficult component of it. We did use a lot of neurological evidence in this case. I did use the concussion CPG to guide me, created by the APTA, and a lot of vestibular and concussion evidence to guide my treatment. So using that vestibular evidence-based practice to make sure we are progressing correctly and giving the correct frequency and duration. This case did help me grow a lot. It challenged me. It is a slightly complex case due to the nature of the post-concussive symptoms and the autonomic nervous system involvement, but challenged me to use those evidence-based outcome measures, and evidence-based intervention taught me a lot of outcome measures I can use to monitor progress over time. And it also taught me that every brain injury is unique, and we just need to really be aware that everybody that presents to the clinic with a brain injury, even if it's just a mild TBI or post-concussive syndromes, we need to treat them as an individual person and treat their symptoms accordingly. And attached are my references here for your reference. Thank you so much for listening today. I hope everybody has a wonderful day.